right, well, we welcome all of you to Students at Work for UNC Lenoir Healthcare. We are a small community hospital located in Kinston, North Carolina. We are currently licensed for about 199 beds, and we offer lots of different services. Even though we are a small community hospital, we take pride in the wide array of care that we can provide to all different types of patients and whatever their needs are. So our mission here at UNC Lenoir Healthcare is to ensure exceptional health care for the people we serve, and we strive to do that each and every day for our patients. Just to give you an idea of some of the services we provide, we have an accredited cancer center, stroke center, bariatric services, cardiac cath lab. We do multiple types of surgery on a daily basis, including bariatric surgery, general surgery, and orthopedic surgery. We have an inpatient and outpatient rehab center. We have radiology services and laboratory services. So my name is Lauren Ginn. I'm a registered nurse and an education specialist in our staff development department. And I do a lot of job shadowing and student at work coordinating for our students. And unfortunately, in light of COVID-19 and the pandemic we're dealing with, we can't have you physically here in the building. But we have come together as a team to provide you a virtual job shadowing and students at work experience. So these three lovely staff members here, my coworkers, are going to be the stars of the show today. So I'm going to let them just introduce themselves and tell you their name and where they work.
Hi, good morning. My name is Elizabeth Wade. I am a certified medical laboratory scientist. I currently work in the lab as the chemistry supervisor.
Good morning. My name is Brian McMahon-Hare, and I am a physical therapist assistant. And I also am kind of Lauren's counterpart for the therapy services department. And I work primarily in the outpatient therapy department and sometimes on the inpatient floors.
Good morning. My name is Lawrence Stanley. I am a radiologic technologist. Sorry, I just totally, I apologize.
We promise he knows what he does.
I promise I did. I promise. I work in the radiology department. I am the clinical imaging supervisor.
Perfect, thank you. So I chose those three areas because from my experience with students, their areas are the most popular areas that students want to job shadow in and learn about healthcare careers within those fields. So now we're going to move into it's almost a 30-minute video for you guys, and these lovely team members here are going to walk you through their department and talk to you about the education required to have careers within those departments and show you lots of cool things. And I just encourage you to think of questions while you're watching these videos, because after the video, we're going to come back for a Q&A session. So think of lots of questions. We're here to answer them. Hey, my name is Lauren Ginn, and I am an RN and an education specialist in staff development here at UNC Lenoir Healthcare. I am the coordinator of our job shadowing programs, and I always look forward every year to hosting our students and allowing you the opportunity to learn about the different health careers that we have. Unfortunately, this year, in light of COVID-19, we cannot have you physically present in the building to get the job shadowing experience, but we have come together and created a virtual job shadowing experience for you with about a 30-minute video of some different areas within our hospital. I know that this is not going to be the same as being here physically, being able to ask questions with our staff members, but the positive out of this is that typically you're here for 2 hours and you only go to one department, but you are going to be able to learn about 3 different departments in a 30-minute time span. Just from working with students in the past, I've learned that some of the most popular areas for our students and the areas that they're most interested in are radiology, the lab, and outpatient physical therapy. So these departments are the ones that you're going to learn about today. I hope that you find this video helpful to you, and I hope that it helps guide you in your future career decisions.
There are 4 main areas that are considered part of the core lab. So we have microbiology, we have hematology, chemistry, we have blood bank or transfusion services. And another subset of the area we have is histology, cytology, and anatomy and pathology. So to work in the main lab, there are 2 separate degrees. You would have a 2-year degree, and you're called a medical lab technologist. And there's also the 4-year degree, which is a medical lab scientist. And there are options for both of those locally for both the 2-year and the 4-year program. Medical technology, and sometimes it's called medical lab scientist or a clinical laboratory scientist, is where basic laboratory science meets the practice of medicine. It's a critical part of the healthcare team where we perform testing that is crucial to helping clinicians diagnose diseases. So I'm currently the chemistry supervisor within the lab. I started off as an MLT, and then I worked my way up to an MLS, and I had a 4-year degree in molecular biology. Then I went back and got an MLT 2-year degree. So I kind of went a little bit backwards, but you see a lot of that.
So one of the things that we do in blood bank is we type and screen. And what she's doing is just trying to figure out what this patient's blood type is. So she's making a dilution. And then she's already dropped in all of the antisera. So she's going to put 1 drop in each one of these tubes. Then the patient's serum is going to be matched. Now we're simply going to centrifuge this for about 15 seconds. One of the other things that we do is we do a screen, and we work in the same method where it's just anti-sera and blood. And if you can see the card, you can see this is a negative result, where the blood cells go settle all the way down to the bottom. And then what we do is once we take it out, is we want to check for agglutination. And we do that by shaking it. And certain patterns will tell us whether you have A, B, AB, or O blood. It will also deduce what your RH factor is. So what do we got? A positive, B positive. Okay, so now that we've seen the first step, what was that patient's blood type, be A positive for that one patient, we would then need to figure out what type of blood. And we have a nice store of it. And we would just go in here and get a unit for the patient. This patient will be A positive. So I'd want to get an A positive unit, just to give you an idea. And then what we're going to do next is we're going to take this blood and we're going to type it up against the patient to make sure that it's an appropriate match. Not only do we give red blood cells, we also give you fresh frozen plasma, or what we call FFP, which is kept in a -30 freezer. So when we go to use it, we thaw it out for each patient as needed. So it's just the liquid portion of your blood. This department is hematology. Basically what we're doing is we're measuring your white blood cells, your red blood cells, and your platelets. And we can help with just 1 drop of blood be able to diagnose whether you have anemia, whether you have cancer, or whether you even have early signs of infection. So sometimes the parameters are well outside of normal, and what we're going to have to do is look at them manually, which means I need to make a smear. So I'm really going to just take 1 drop of blood. And I'm going to make a smear. And then what I'm going to do, what I'm looking for is a nice feathered edge, so it looks kind of like rounded at the edge. And then I'm going to sit there, and I'm going to let it dry, and then we're going to stain it. And next what we're going to do is we're going to count the cells that are on there. All right, so this department is chemistry. It tends to be the workhorse of the lab since we do so many tests. It's the most automated section of the lab, where we just centrifuge down a specimen, and we're going to be working off of the plasma or the serum, the liquid portion of your blood. Now with this, we can detect your liver function, your kidney function. We can tell whether you have diabetes, whether you've had a myocardial infarction or heart attack. We can detect whether you are in diabetic ketoacidosis. We can check your therapeutic drug levels, and yes, we can even check for recreational drugs with drug screens. So on the outside, chemistry seems really automated and really simplistic, but when you look inside, you really see that there's a lot more to chemistry. So on board this analyzer, there is a spectrophotometer, an nephelometer. We do immunoturbidimetric methods, a lot of different assays that measure a lot of different ways. So this is microbiology, and what we're doing in here is we're isolating organisms. We're going to identify them, and then we're going to check that, see which type of drugs work best to combat the infection. We have all sorts of sources. If it's in the body, you have spinal fluid, we do blood cultures, we do urine cultures, and we're able to let physicians know and help them figure out what's the best course of action to help improve patient outcomes. So as you can see, what she's doing, she's isolated a colony, and she's going to put it on the plate. Now what we have here is a multi-top analyzer, which stands for multi-accelerated linear deabsorption ionization time of flight assay, which is just a fancy term for a really fancy spectrophotometer. Okay, one of the other different departments that we have is anatomy and pathology. And this is where they do what we call grossing. And it's not because it's gross, but it's about taking larger organs, such as like a pancreas or a colon, and helping dissect it down into little pieces, so that then they're going to embed it in formalin so that they can slice it down and stain it, so that the pathologist can try and deduce what is wrong with the patient. So here is our wonderful grossing table. So one of the other positions that we have is phlebotomy. Now this is a little bit different than the rest of the lab, and it is one of the only parts of the lab that it has a lot more one-on-one patient contact. And sometimes it's the only person that you're going to see from the lab. And what they do is they're the ones that collect the specimens for us. They go throughout all the hospital, and they take each, as you can see, there's different types of tubes. They all correspond to different departments within the lab. So we have chemistry tubes, we have hematology tubes, coag tubes, blood bank tubes, and more chemistry tubes. So it's a really great way to get started in healthcare. If you're not really sure if this is what you're looking for, if you're interested in allied health in general, it's a really great way to get inside the lab and just to see if you like it or not. So in order to become a phlebotomist, what type of education would prepare them for that? So a lot of times, a lot of local colleges will offer a certification program, and usually it's can be a couple weeks up until a couple months for you to be certified, and then you can very easily walk into a hospital and get a position.
Okay, in the radiology department, our department is actually made up of a number of subspecialties. We offer diagnostic X-ray, ultrasound, CAT scan, MRI. The general starting point for most in this profession is diagnostic X-ray. It's a 2-year program. It's supported by many community colleges. However, there are a number of 4-year universities that also have radiology departments. So you can either go the route of a community college and get an associate's degree in radiologic technology, or you could go to a 4-year college and get a bachelor's degree. The difference would be probably moving towards management if you get a bachelor's degree versus an associate's degree. That would be the difference there. But once you achieve that level of education, you can move on to what we call post-secondary specialties like CAT scan, ultrasound, nuclear medicine.
And that takes additional.
That's additional
Additional
program. Yeah, through a program. Again, usually they're through community colleges. The length of time just varies on what type of specialty you move towards. I am the clinical imaging supervisor. So what that means is I oversee the day-to-day clinical operations of the entire department. I'm responsible for making sure that each area is appropriately staffed, and make sure that like we're supposed to every day. I'm also overall like reference for policies and protocols and procedures for different areas to make sure that we're following regulatory guidelines. I actually wear a number of hats, and it just really depends on the day. It depends on what I'm doing, but it's always an interesting job. I am board certified in diagnostic X-ray, computed tomography, and MRI. I have a bachelor's degree in radiologic science, and I have a master's degree in information technology. Okay, so this is one of our CT scanners that we got back here in CAT scan. This one is made by GE. It's what we call the 64 slice EVO. CAT scan is a type of X-ray where we're actually looking at the human body in a cross-sectional point of view. The way we explain that, the most popular way to explain that is you take a loaf of bread and you slice it from one end to the other, and you can take any slice out of that loaf and just look at it. That's how basically we look at the human body using this type of scanner. CT scanners are very highly detailed imaging of the human body. Give doctors enormous amount of information on what's going on with that patient so they can make a very accurate diagnosis. So here we're in the nuclear medicine department. This is one of the nuclear medicine cameras that they use to do their examinations. Nuclear medicine is a little bit different, where they're actually looking at functionality of organs, where on a CT scan you can look at the liver and you can describe how it looks, how big it is, if there's any abnormalities. Where in nuclear medicine, they're looking at how it actually works. They utilize radioactive isotopes that they inject into the bloodstream, and they take images of what the patient gives back. So we're here in one of our diagnostic X-ray rooms. Diagnostic X-ray room consists of an X-ray tube here. This is the part of the machine that actually produces the X-ray beam that passes through the patient and creates an image. This is the X-ray table where procedures where the patient has to be laying down are performed. And we also have the upright chest bucket here for upright procedures, like the most common would be a chest X-ray. So the patient would stand in front of this, and we would shoot that X-ray beam through the patient onto this here that collects all that data. Okay, this is one of our portable X-ray units. There are situations where a patient is in a condition, a critical condition, where they really can't be moved to come down to X-ray to get X-ray. So we have equipment that's actually mobile that an X-ray technologist can take to the patient and get those X-rays that are needed. All right, this is one of our ultrasound units that we have for ultrasound. Ultrasound is interesting modality of X-ray because it actually does not produce any kind of ionizing radiation to obtain the imaging that they do. It's actually ultrasonic. So even though it's not an X-ray procedure, ultrasound is very much part of the radiology department. Okay, this is the MRI department. MRI, like ultrasound, is different because it's not utilizing X-ray. MRI utilizes radio frequencies and an extremely high magnetic field to produce the images that they do. MRI is extremely sensitive and very detailed when looking at human anatomy. Some of the drawbacks to MRI is it takes a little bit longer than a CAT scan or a regular X-ray, and it makes a lot of noise, but the benefit is being able to produce images with great detail and the ability to make really highly accurate diagnoses for patients.
I work in the rehab services department, and so that is physical, speech, and occupational therapy. And depending on the discipline, my discipline is physical therapy, and so we are what you would consider movement experts. We do any and everything as far as hands-on or using machines or equipment to help to facilitate movement for a patient to make them more independent in their daily life. So starting, I guess, at the top, you have your physical therapist. We have licensed physical therapists practicing in the profession currently that are ranging between a bachelor's degree in physical therapy, which would be licensed kind of a long time ago, all the way up to a doctorate in physical therapy, which is the current education and licensure level that we're seeing come out of programs. So anywhere from 4 years to 7 and a little bit better years as far as educational time. And you also have your physical therapist assistants. That's an associates in applied sciences. And so that's about a 2 to 3 year time commitment within that program, just when you separate out the classroom versus didactic learning. The physical therapist is responsible for the initial evaluation of any and every patient that we see. So they're going to get a doctor's order, and based on what the diagnosis is on that doctor's order and the patient's personal health history, they'll come up with kind of an overall health status and then do tests and measures. So measuring joint motion, measuring strength, testing their balance, and seeing where exactly their deficiencies lie so that they can make a treatment plan. From that treatment plan, they typically would then hand off the responsibility of the treatment to an assistant. And as an assistant, you are not doing any evaluation, technically speaking. However, just like a nurse would constantly assess a patient's status, it is the responsibility of the assistant to continually assess a patient's status, modify the treatment within the plan of care, and communicate any and all progress and or difficulties towards progress to the physical therapist. I am a physical therapist assistant. I have an AAS, which is an Associates in Applied Sciences in Physical Therapy, and I am also the student coordinator for the departments. Okay, so what I'm doing is working with a patient, again, to work on her overall mobility. So let's say this is a patient who has a hard time getting up out of the bed. Rather than just give her verbal instructions about how to get up out of the bed at home, I'm actually going to take her through that process. In an outpatient setting, that would be probably more practice than anything. In the inpatient setting, that's how the nurses are going to get the patient up out of the bed, is to actually teach them how to help in the transfer. So what you're going to do, Ms. Wade, is we're going to roll over onto your left side facing me. I'm not going to let you fall off of this table, okay? And then once you get on your side, I'm going to help you to sit up to the edge of the bed, okay? Always tell a patient what you're doing before you do it, because otherwise you can start from. Okay? And now what you're going to she's a therapist, so she knows what I'm going to say. So what you're going to do is at the same time, you're going to let these legs come off of the mat table and push through your arm, and I'm going to give you a little bit of help through your shoulder. And once you've got them sitting up to the edge of the bed, then you would want to adjust the height of the bed so that their feet are touching the floor, if that is a possibility. And then once we've got them seated, we may have to work on their seated balance a little bit. As you can see, she's able to maintain her balance without any help from me. So we're going to go right to standing. I'm going to put this belt around her, a gait belt. is not just for walking. It's for any time that you may need to give that patient a little bit of physical assistance or help. And it's not just for their safety, it's for your safety, because you can get yourself in a bad way if you don't use them. Okay, this way what we're going to do is, before you stand up, I want you to scoot forward on that bed right to the edge. More, very good. And I want you to get your feet about shoulder width apart, nice and wide apart. Okay, the next piece of this puzzle is, before you stand up, what I want you to do is lean forward like you're looking at your feet. Once you get lean, I'll give you as much or as little help as you need. I want you to stand up, okay? Go on 3. 1, 2, 3. Stand right on up. And again, even if that patient doesn't have significant difficulty standing up, you do still want to keep hands on them and make sure that they're okay in their standing balance. Some patients can get a little bit of dizziness when they change their position, especially quickly. All right, she's standing there really well, so I'm going to have her sit back down. Reach back to that bed. And I'm going to get a walker, and we're going to walk on a little bit of what we call gait training. It's just a fancy way of saying teaching someone how to walk, or how to walk safely and correctly. Okay, this way we're going to do that exact same thing again. You're going to lean forward and stand up and put your hands right to that walker. Okay, you want to stay pretty close to this walker, but don't walk ahead of it. Okay, and we're just going to kind of turn to your left-hand side and walk through the door. So Miss Wade is having a hard time with her walking, and she's had some falls in the house because she's not picking her feet up quite like she should while she's walking with her walker. So the first thing I'm going to tell her is to stand up nice and straight with that walker. Can you stand up nice and tall for me? Can you pick your head up and kind of look out like you're trying to look at the horizon? That's right. All right. And now when you take a step, what I want you to think about doing is taking a nice long step and trying to get the heel of your foot down first. That's good. Nice big steps. So now, with Miss Wade, what we're going to work on is doing some balance training. So what I have here in front of me is actually, you may have seen them in gyms, it's a balance band, but this one is made of foam. And so it's going to really challenge her ability to stabilize herself. And what I'm going to have you do this way is you're going to walk heel toe. Okay, so you're going to walk one foot in front of the other like you're walking that line. Okay. And if you start to lose your balance, I'm here to help you, okay? Whenever you're ready. And I'm going to give her cues that help with the balance, like tighten your tummy, try and bring your head up. And you can see that this is really challenging her. But this is a way that we can train the brain and the nerves and the muscles in such a way that in most people's daily lives, they're not walking on a foam balance beam. But if you can walk on a foam balance beam, you can probably walk across your yard to get to the mailbox. Okay, so what we have here is just a basic step stool that you probably have one around your house. We like to use as much as we like our Gidgets and our Gazmos. To have something that a patient can recreate in their home is very valuable, because then that helps improve their ability to do the strengthening exercises on their own. So the first level for a step up is just a basic step up. Stepping up on the stool, stepping back down. So I'm going to have you take your right foot and put it up on that step. You always want to stabilize whatever you're stepping to, just in case we have a little balance problem. And then whenever you're ready, you're going to bring yourself up on the step. Keep that right foot up, and you're going to bring your left one back down behind it. Okay, so let's say they've done this for a couple of weeks and they've gotten really strong in it, and I want to help to challenge their balance and their strength a little bit more. I might ask them to do a power step up, which is something where they do the exact same thing, only they bring that leg all the way up in the air. And that works on their ability to balance on a single leg, to stabilize at their hip, to stabilize at their core and at their knees. So it's a, as I like to call it, a good bang for your buck exercise. Okay, so moving on within progressing a patient, obviously this is kind of a rapid progression. We wouldn't do all of this in one day normally. But that same patient, or maybe a younger athletic patient, has some issues with their agility, their speed when they're playing their sport. We may get out something like this agility ladder and teach them how to work on their agility, work on their foot placement, things like that. So I would just always demonstrate it to the patient, because these become very difficult to explain in a way that they can return that that instruction. So what we're going to do here is we're going to work on your footwork and your ability to stand on one leg. So we're going to do 1, 2, 3 in each box. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. You notice that I didn't go through that full speed all the way, because when a patient first starts doing these, we're usually going to start at like quarter speed or just walking the exercise through, rather than having them trying to go as fast as they can. And the reason for that is if they were to try and go as fast as they can right to start, it's going to be really messy and not what we're looking for. All right, so you ready to try this? I think. All right, we're going to do 3 in each box. And I'm going to count for them. Sometimes I can kind of clap out a beat. Okay. 1, 2, 3. 1, 2, 3. Good. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
I hope that this video gave you some insight into what it's like to work in healthcare careers.
And Lauren, I had to mute your microphone during the video, so you want to come unmute it?
All right, can everyone hear us?
Sound great, thank you.
All right, thank you. All right, so that was our video, and now we're just going to open it up for Q&A time. Any questions you guys have for us? I think someone's going to read it to us.
Our first question is from Robin. It's, what type of undergraduate degree do you need for PT, physical therapy?
Just go ahead and answer. I'm sorry, y'all. I'm not tech savvy. That's a really good question, and the answer is, in theory, I had a coworker years ago who went to PT school, and his undergraduate was in theory. You do not need a specific undergraduate degree to get into a physical therapy program. However, if I had to make a recommendation, I would say something that is more science heavy. Biology, kinesiology, psychology would probably improve your chances of getting into a PT program, because they are highly, highly competitive. But I have had physical therapists that I've worked with degrees, like I said, one in theater. That was kind of an outlier. But I've known English majors, history majors to end up going back and getting a physical therapy degree. My original undergraduate is in education, which kind of moved me into therapy pretty easily. But if I had to make a recommendation, something that is more towards the science realm of things, and kinesiology type degrees that like ECU has a really good kinesiology degree that would almost be like a pre-PT type degree.
All right, so our second question is from Zaya. They wanted to know, with the blood area, how can you tell if they have cancer?
Very good question. So when I was discussing hematology, some of the early indicators that can show up on the blood smear that I was showing you with the patterns in their white blood cells, whether they're more than should be normal or less than should be normal, or even in your red blood cell or platelet numbers. They can all kind of give us an indicator that maybe something's not right. Also, there will be cells that are usually not normally found on a blood smear that can really make us flag the pathologist to maybe take a look at it and decide if there need to be further studies or referral to our oncologist.
We have another question. Can you talk about salaries in your areas and then how these progress throughout your career?
Which person was this to?
I guess is that for every area, all three?
It was just a general yes. They
Okay.
said yes.
Yes.
Lauren, take the hit.
No, I gotta take it. Salaries are salaries in the radiology field. There's a very broad range. depending on the type of radiology is broken. As I said in the video, radiology is divided into several subspecialties. As far as salaries are concerned, salaries are really based on experience also. So just to give you just a very basic salary, coming straight out of X-ray school, you would make somewhere around about $22 an hour for an X-ray tech, and it would be higher for any other subspecialty. CT would be higher, MRI would be higher, nuclear medicine would be a higher salary.
Oh, me. Okay. So in physical therapy, I would kind of have to reiterate what Lawrence said in that there, depending on where you are working once you come out of school, is going to largely determine what type of pay rate you're going to get. So obviously, or maybe not so obviously, a physical therapist assistant, being that they are educated at an associate's level, is going to start out and pretty much always make less money than a physical therapist. So if you're starting as a physical therapist assistant, it's interesting in that usually the most desired jobs coming out of school are the ones that pay the least. Meaning every student that I have comes into the clinic saying that they want to work in an outpatient orthopedic sports medicine type setting. That is your setting that's going to be the lowest compensated. And then you have kind of the next level up would be outpatient hospital based. Next level up would be hospital based acute care. Next level up would be skilled nursing and long-term rehab. You could expect, I would say, to make within those levels somewhere starting out between $45,000 and $55,000 a year if you're working full time. And you know, obviously that is going to vary based on the area of the country that you live in and things like that. As a physical therapist, the exact same levels and tiers as far as pay rate are existent. So you're going to make the least money outpatient orthopedic. You're going to make the most money working in a skilled nursing type setting. And I would say right now, if you're graduating with a doctorate in physical therapy, you would expect to make probably no less than $65,000 to $70,000 a year, all the way up to maybe $80,000 a year. And then based on experience, those pay rates and the amount of responsibility that you take on within your facility or your department it's going to go up.
And I have to agree with them. It does depend on how tiered it is, what degree you have, how much experience, where you live, also even the demand for the positions. Because phlebotomy is more of an entry level. When you have your MLT, then you have your MLSs, and then you go up into management all the way up to a lab director, which sometimes they can even have doctorate degrees. But I had to put a range. I'd say it's kind of equivalent for any type of entry level to make around probably low 20s an hour as an introductory rate for a 2-year degree.
All right, for our next question, it is with the physical therapist, if someone were to have a football or any other sport injury, how would you help them get better?
Well, that's a big question. I've worked with a lot of football athletes in the not 10 years. I've been working for 17 years, guys. I just forget that sometimes. I've worked with many football athletes, and the treatment is going to vary largely based on the mechanism of injury, meaning how they were injured, the severity of injury, how bad it is, and what exact injury took place. I mean, football is a contact sport, and when you are being, and if anyone on this call plays football, you can understand if someone who weighs 250 pounds is running at you full force and gets you to the ground, that can cause injuries all the way from finger injuries, elbow, wrist, shoulder, to back injuries, hip, knee, ankle, foot, you know, kind of anywhere in the gamut. So we're going to get them in and we're going to do an assessment, and we're going to both look at what is injured. If there are any, if they've had a surgery, there may be a post-operative protocol. So let's say I've had a football athlete, not a very common, but a relatively common football injury that I see is called the terrible triad. It is when a patient has had a mechanical force, usually to the outside of the knee, and they tear their ACL, they usually tear a meniscus and lateral collateral or medial collateral ligament. And when that happens, there's almost always going to be a surgical repair, meaning a surgeon is going to take them into an OR, repair everything as best they can, close them up, put them in a long leg brace, which, as you've probably seen, is a brace that starts at the hip and goes down to the ankle. It'll be locked out, and they'll come into me on crutches, non-weight bearing. And I'm going to start with very gentle exercises to work on their range of motion and their strength. And I have to look at the protocol that the doctor gives me, because every patient is going to be different. And there may be things I'm allowed or not allowed to do. So as you progress through that protocol, you're going to work on, you know, more dynamic strengthening exercises, more aggressive range of motion. Then, you know, we get further into the protocol, and then we're really working on balance, stability, agility, you know, just strength training, cardiovascular endurance. Because if you're used to exercising for 4 hours a day and you get injured and you're exercising for maybe 30 minutes to an hour a day at a much lower level, a big part of what we do is getting someone back ready to play in a game and not be completely gassed out halfway through. So sometimes my football players, I'll end up by the end, you know, in the beginning, it's very low level and there's lots of ice and sweet words. And by the end, I'm yelling at them and telling them, you know, if they can talk, that they're not working hard enough. And they're working 90 minutes with me. So it really depends on the injury, but that's kind of a basic genesis of what we would do.
All right, for our next question, can you each talk about the skills and different personality traits you need on a regular basis to do each of your jobs?
It's a great question.
Let's start.
Just talk.
Stop
throwing me under the bus.
Personalities. Well, in radiology, we are very patient hands-on. So you do have to have a great deal of compassion, patience, understanding. We see patients from every aspect coming in for different types of examinations. Some are straight from the emergency room, from trauma situations. Some patients are just outpatients coming in for routine procedures. So you're going to have a broad range of personalities that you'll be dealing with as far as patients are concerned. So I would say you have to have all those qualities. You have to be someone who's a people person, as well as a little bit of a nerd to work with all of the different equipment that we utilize every day. So those are the top qualities for my profession.
So for physical therapy, I'm just going to keep copying what you say. No, for physical therapy, I would absolutely agree. Anywhere in healthcare, on any level, from the people who are at the highest levels of our hospital making all the big decisions, to the people who, you know, my boss, and, you know, anywhere, even the people who work in our nutrition services and our housekeeping departments. I think you have to have just a baseline level of compassion and empathy for the human condition. Because if you don't, that shows. And beyond that, absolutely, you need to be a people person. I don't think I necessarily came into this profession, you know, a million years ago as a people person. I was much more introverted. I felt like there were like these really long, awkward pauses in my treatment sessions that can last anywhere from 30 minutes to 90 minutes. And I had to kind of pull myself out of my shell and start to try and be able to relate to my patient, not necessarily about their injury or what was going on with them, because you need to have compassion and empathy for that, but they don't necessarily want sympathy. But more like I have my big three. I love, love, love to talk about my dogs. I have a badge button that says ask me about my pets because I love talking about them so much. And if we had more time, I'd tell you guys all about them. I love to talk about cooking and food. I love to cook. I consider myself a novice chef. And now that I'm married and have a child, I love talking about my kid. I love talking about my family. And so I think if you can attach and kind of create a bond with a patient on any level, whether it's food or dogs or cats or sport, your family, your faith, anything, I think that makes the treatment, it makes them more comfortable with you. It breaks down that kind of wall and that barrier of fear and anxiety, and you can kind of push through to get them their best outcomes. And that's going to change from patient to patient. Like I say, with my athletes, I'm yelling at them and telling them they're not working hard enough. Well, if I told Grandma Betty that she wasn't working hard enough and yelled at her, she'd probably cry, and her kids or her husband would come in and tell me about myself. So it's adaptability and being able to kind of be the person that they need in the room.
So the lab is a little bit different. We actually, except for phlebotomy, where I do agree that it is patient-centered care, you do have to have compassion to be able to identify with your patients on some level. But most of the people that work in the lab do not have patient access. And so if for you want to work in a medical field and you're just like, well, I'm not sure if I really want to deal with patients on a regular basis, it's a great way to get in the field and say, oh, do I like this or do I want to branch out? We have a lot of people that do start off as phlebotomists and then go into nursing programs, kind of as like a transition. For most of us in the lab, we are quite nerdy. We're very science-based. We really have to, you're still working with people, so it doesn't matter where you go, you do need to have really good people skills and communication skills. But in the lab, you have to have higher level critical thinking skills to be able to interpret a lot of the labs that are coming out of there and making sure that they match up with your patient's diagnosis before you release it out to your physicians. I think that's about it. Sorry.
And I can speak really quick to nursing. I know it wasn't in the video, but just to compile everything they just said, you definitely need that for nursing, but you also have to be flexible because healthcare is always changing. You're always having to learn new policies, processes, equipment, everything. It's always changing. And then also you have to be an advocate for your patient. And that means you have to stand up for what's best and right for your patient.
Mm-hmm.
All right, for our next question, when the lady was showing us how to help someone get out of the bed who was having trouble, how long would it take for the patient to get their balance better?
That depends largely on the age of the patient, the health status of the patient, and any existing conditions that they're experiencing. So what I mean by that is someone who has been in the bed for a long period of time is going to require significantly more time and probably support in that initial seated position than someone who maybe came in through the ED and just maybe is having a little bit of back pain or something like that. Then you also have to look at this issue of, here's a big word, I haven't used a lot of them, orthostatic hypotension, which is something that when you change position, every position that you're in, your blood pressure, your normal blood pressure would be different. That's why when you go to the doctor's office, they make you uncross your legs, put your feet flat on the floor, sit up straight, and elevate your arm, because that's kind of the optimal position. But laying down, laying on your stomach versus your back, sitting up, supported versus unsupported, standing, all of those positions are going to change your blood pressure. So if you're a little bit older, you have a little bit of a cardiovascular issue, when you change positions, your body needs a little bit of extra time to account for that change. And so what that extra time creates, it can be dizziness, it can be a feeling of lightheadedness or even blurred vision. And so sometimes that process of just getting someone from laying down to sitting up on the edge of the bed independently it's not a matter of minutes. It can be a matter of days. It can be a matter of, number of treatment sessions that, there are times when I document and very excitedly that a patient tolerated sitting edge of bed for 30 seconds before requiring support. Then you have patients who are out of the bed before you're even fully in the room, and they're perfectly fine and standing there, usually in a relative state of undress. So it really depends on the patient and what else is going on with their health. But it can take several days of treatment to actually get them to that ability. Did I answer that? Mm-hmm. Okay.
I had a question personally. I wanted to know, like, what institutions are the best to actually go into in the state to go into each of your professions?
Institutions, what colleges offer degrees for profession
Oh,
around here.
okay. Well, for radiology, it's a 2-year associate degree. So in our area, we have Lenoir Community College, which is an excellent college to get your associate's degree in radiologic technology. Pitt Community College also has a program as well. So both of those programs are very good programs for X-ray.
It's okay.
Aside that, the other subspecialties kind of follow along the same line. MRI, CT, Pitt Community College has a program for MRI, CT, ultrasound, nuclear medicine. All the same, depending on the specialty, will depend on how long you actually go to school. X-ray is 2 years, no matter where you go. For CAT scan, it could be another semester for CAT scan. MRI could be a semester or up to a year for MRI, as well as ultrasound.
So for physical therapy, obviously it's going to vary depending on the degree level. So physical therapist assistant programs in our direct area, as far as we're in Lenoir County, we have 3 that are relatively close. One is Craven Community College. The other is Nash Community College in Rocky Mount. Craven Community College is in New Bern. And the third, which is my alma mater, is Martin Community College in Williamston. There are many, many more throughout the state, but those are just the 3 that I regularly work with. For physical therapy, obviously you're looking at a doctorate level degree, so you're looking at a university. There are actually probably more PT programs in the state than PTA programs. So ECU has a great PT program, UNC has a great PT program, Duke has a great PT program, there's Methodist, I'm seeing some great therapists come out of there, there's Campbell University, there's Elon, there's Western Carolina, and do some research, but all of the schools that I have worked with are producing really great therapists at the end of the day.
It does depend again. There are 2-year and 4-year degree programs for the lab. For phlebotomy, we also, as you know, Lenoir Community College does have a wonderful program for that. They actually do the clinical rotations here on site. For a 2-year degree in the area, I know that Beaufort has a program. Coastal Carolina and Jacksonville has a program. I believe Wayne also has a program. Those are in the immediate vicinity, and there's probably loads more all across the state. For a 4-year program, there, I believe, is still one at ECU for right now. NC State and UNC also have 4-year programs available.
All right, so we have one last question. It is, do you know about rheumatology?
About rheumatology. I know about rheumatology and that what tests a physician would order and how to interpret the tests. So I don't know probably as much as the physician probably would know. A lot of times when they think that you have rheumatology, they would order just a screen. It's just a simple yes or no, and then we also can send off a lot more confirmatory tests. And that's probably the extent of my knowledge. I'm not sure if they do anything
Well, I probably want clarification on the question. I mean, just as far as what a rheumatologist does, or what, you know, we deal with rheumatic conditions. Most people think rheumatoid arthritis is the only one. They're actually not. So scleroderma, I've seen patients with scleroderma, which is technically a rheumatic condition. You know, anything where your body is fighting itself is considered a rheumatic condition, kind of towards the autoimmune side of things. So we see many patients who carry a diagnosis of a rheumatic condition that may not be what I'm treating them for, but it is a consideration, obviously. And then I see patients that I'm actually treating them for a condition that would be considered rheumatic. And it's just something that you have to really do your research. That kind of goes back to the nerdy thing that we've all been saying, and know what's going to work best for that patient and what they're going to tolerate and what they're not going to tolerate, and what could possibly cause an exacerbation of their symptoms, which obviously we would always want to avoid.
And to go back to it, a lot of these are autoimmune, so that really falls under a different subset under immunology, which is really diverse and complex. There's a lot of pieces that can cause a different piece, different types of diagnosis, and they don't all hit the same pieces. So.
I really like this question, so we can finish off with this one right here. They wanted to know, have you guys talked about occupational therapy for helping with things like autism and physical mental disabilities?
Okay, so that's me. Okay, so occupational therapy, and I am the worst because I am married to an occupational therapist. I have sat here and talked all about physical therapy and not mentioned our kind of sister profession of occupational therapy. So occupational therapy, when dealing with, specifically if you're talking about autism, I tend to say I don't treat autism. I do work with pediatrics, but meaning that autism is not really a treatable diagnosis for occupational physical therapy, any of the therapies. What we're dealing more with are the issues that have been created by that autism spectrum disorder. So if a child, and it is such a spectrum. I have children who carry a diagnosis of autism who are completely age appropriately functioning in classrooms. Maybe they're struggling with their social skills. And then I have children who have significant sensory disruption, sensory issues that may be causing behavioral issues. So really with autism spectrum disorder, you have to get to the root of, and that is largely done, I'm sorry, I kind of backtracked. Whether you're occupational therapy or physical therapy, what you're going to do first and foremost is a pretty general screen. The most common one that we see is the PDMS, Peabody Developmental Motor Scale. And so what we do with that is we do an assessment of the child to see if they can do this skill. Can you hold something with this type of grasp? Can you complete this puzzle? Can you match these colors? Can you jump? Can you hop? Can you walk? Can you do these transitional movements such as sitting to crawling to tall kneeling to standing? And depending on what you're able to do within that PDMS is what your developmental age is. So what I need to do when I am treating a child with any type of developmental delay spectrum disorder is look at their actual chronological age, account for any things that might be decreasing that chronological age, such as being born premature. If you're born premature, we actually don't age you at your chronological age. We age you at how many months you would be when you were due, because that does come into play. And then I'm looking at where they fall on that developmental age and what I need to do to facilitate them getting to those two numbers closer together. So bringing their developmental age up to their chronological age. But then also there are children who I treat and who occupational therapists might treat for, behavioral issues, that they come in and they blow the PDMS out of the water. They're actually testing 6 months ahead of what their chronological age is, but they can't sit in a classroom long enough to be educated appropriately. And so then that's a treatment that we're working really on behavioral issues and possibly some emotional issues. Usually there's a mental health professional involved in their care as well. So it really depends on what issues that they're coming to us with and how they're presenting when they do come to us as far as their age appropriateness.
All right, thank you for answering all these questions. That's going to wrap up our Q&A for this session. Guys, any goodbyes, any wrap-up messages?
I just wanted to say thank you all so much for tuning in to our Students at Work session. It's been very different this year, but glad we're still able to expose you and introduce you to healthcare careers. And any questions you have that we were not able to answer, I believe will be sent to me. So I will distribute those out to whoever they need to go to and get the answers back to you all so that your teachers and educators can share the answers with you. So thank you so much for your time and your engagement, and we hope you have a great day.
Thank you.
All right.